I'm not seeing your screen. There. Phew. Not me.
All right, good evening, everyone, and welcome to the live NREMT review session. It's April 30th. My name is Dan Limmer, and we're going to get started now. We have a lot of people signed up here, and they're coming into the room as we speak. Limmer Education is a company that's really all about helping you pass the National Registry, and I'm very glad that you came by today. Now, we're going to go over a few ground rules before we start. Go to webinar control panel that you see on your screen. There's a place that says questions, and pop that out. And any questions you have for us, send those along as we go, and we'll try and answer some of those questions live during the webinar, as well as being able to send out some answers to some of the more popular questions afterwards. Also in the GoToWebinar control panel, you'll see some handouts. In there, we have our 4 steps for evaluating NREMT questions. We're going to go over that as part of this webinar, and also some information on products and a discount code for those products. So that is the plan for today, and I think we should go. I think I can start by introducing myself. My name is Dan Limmer, one of the founders of Limmer Education and Chief Knowledge Officer. The good fortune to be in public safety for really for now, I guess, more than 40 years. And as a paramedic, a police officer, educator, I'm happy to speak at conferences quite a bit. And I've written several EMS textbooks. If your EMT book, if you're here for EMT and your EMT textbook is yellow, I know you don't always know the title of the authors, that would be the book. And it is my job here today to help you with the National Registry. Limmer Education has actually been doing this for about 10 years. I'd like to think we get better every year at doing that. So we're going to get into that right now. Now, a philosophy that we've developed over time is that there are 3 things that I personally believe that you need to know or to do or to have to pass the National Registry. The first of those things is knowledge. The National Registry will give you questions that will start a little below the expected competency level of an EMT, and they will gradually get more challenging. It's important that you know your course material. And by the way, this session would be good whether you're here to prepare for EMT, AEMT, paramedic, EMR, whatever you're doing, this session will apply to you. And you need to know the knowledge that is part of the education standards that cover your course. Now, the second thing, and I think something that gets people quite frequently, is seeing National Registry style questions. And these just seem like they're written a little bit more, a little differently than the ones you're used to in class. And quite frankly, it can mess with your head when you sit down there. You walk into those test centers, which I hope will be open soon. Some have been, others, will be as we go. And you get in there, and all of a sudden, you've got this pressure on you, and then these questions come up on the screen. And if you've seen the memes and stuff out there, and Facebook groups, wherever it happen to be, where it's like they're written in another language. And we're going to talk about how the questions are written today and help you prepare for those. You need to be able to understand them before you go in. That's not the time to figure it out. And the last thing I think you need is I think you need some mojo. You need to believe that you can pass the test. Now, at the EMT level, the most popular level tested, about 70%, and it ranges year by year from 68 to 70 or 71% that pass the first time they go to the test center. And that's good. And quite frankly, a certification test for something important, as important as EMT or AEMT or paramedic, shouldn't be easy. But that does mean there will be people that don't pass, and don't ever give up. I want you to go back and I want you to succeed, but it does knock down your mojo a little bit. I mean, it really does. So we've got to get you to the point where you believe that you can go in and pass the exam. I mean, it is just that important. And, the way you study is very important as well. So we have exam prep products, our EMT and AEMT and paramedic review, our EMT, AEMT, and paramedic pass. I'll talk about the pass apps in a second here. But when you use these, right now, what people like to do is have test questions and practice. You get through with the class and you want to practice. So you go through and you take a test question, you see if you got it right or wrong, and boom, you move on to the next one. I'd like to give you a little bit of a different plan, especially when you're using really good questions, like we give you here at Limmer Education. So the first thing you want to do, this is probably not a bullet to anyone, is to read the question. Okay, it's very important that you read the question. Choose an answer. All right, that's good. But if you get it wrong, look back at the question and figure out what it is that you missed that would have helped you get the question right. Right? With questions that are written like the National Registry gives you 4 choices. And in those 4 choices, everything is a little bit choosable. Right? And they're going to ask you for a conclusion or a decision or something serious, not just to remember what bone is in the upper arm, or, they're going to give you a question you're going to have to think about. So read it, pick an answer. And while you're getting ready and you're preparing for the test, get the answer, and maybe there's a rationale. Read the rationale, and then go up to the question and say, what did I miss in this question that would have helped me get the answer right? That's how you need to be able to do this. And the last thing is that, keep a pad by you. Maybe it's a tablet, a pad. But every time you see something you don't know, write it down so you can look it up. Right? That way you're studying smart. Listen, I write an EMT book. I don't want you to love my book, but if you read the book, did your homework, and paid attention in class, the number of people that tell me, oh, I read the book a couple of times, or I went through the book a couple of times to prepare. If you've already done that, get some good test questions and let that determine what you need to study. If you say, okay, I'm bombing out on OB questions, well, then go back to the book and go to OB. But study smart. It's a really important thing that I want you to do. Now, I told you about some of the apps we have. I just want to talk a second about these pass apps. We have these pass apps for EMT, AEMT, and paramedic. You can see these icons. Our apps are available on the Apple and the Google Play stores, as well as at our site at lc-ready.com. And if you download the flyer from the handout, you'll get a discount code to use on our website. When you go to the National Registry, you're going to walk out of there and you're going to be scratching your head. I don't know a lot of people that ever said, well, gee, that was easy, or I knew all the words, or all those questions made sense. That doesn't happen. It really doesn't. Back when Bill Brown, the former executive director of the National Registry of EMTs, retired, I went to him and said, Bill, we're doing these apps. I want to do some really good apps. I want people who know how to write these questions. So Bill Brown from the NREMT, wrote these questions. We also have a former exam coordinator that goes through and reviews questions, both who have worked at the NREMT. I feel very confident we've got the best questions out there. Do you know how I know? They're going to make you crazy and scratch your head, just like the National Registry. There's times we get emails from students. Oh, gee, this doesn't match my book, or this is what my instructor said. Well, the National Registry isn't going to either. Doesn't matter what book you use. It doesn't matter what your instructor said. Doesn't matter what your protocols say. You need to not only have the knowledge, like I talked about earlier, but I want you to have the experience taking these questions, so you get to the National Registry and you're going to feel like you've already had questions like that before. It's going to help keep your head clearer. I mean, it really is. I joke around. I've been teaching for a long time. Right now, in East Texas, I'm teaching at Galveston College. I'm doing an EMT and an AEMD class, and we've had probably a lot of the same challenges that you've had. You couldn't go into school, and some of the skills and clinicals have been canceled. I mean, things are really crazy. Then they closed the Pearson View Centers. I mean, you're a student in a time like no other time in EMS. I mean, really, the challenges, that you've had in front of you. But these questions are going to get you into a position where you're confident and you are ready to take the test. You will know what those questions look like before you go in, and you'll do them. Bill, I always joke, writes questions. I always say they're somewhere between amazing and evil. Some of those questions you're going to look at, even me as an educator, and somebody writes a textbook, looks at those questions. And I don't take these tests and get 100. You're not going to either. Nobody gets 100 on the National Registry. They give you harder questions until you get one wrong, right? So lean into it. Use good questions, and we're going to go on. It's time for us really to get into some questions here. I'm just kind of looking through at the some of the questions that people are putting in here. Just say really quickly, I can't really compare myself to other things. I'm not going to say anything bad about any of the things. A couple people have asked about specific apps. I think we have the best stuff out there. I mean, so I can say that. Everyone who's written our exam questions has written for the National Registry. They've gone to Columbus, Ohio, usually more than once. They've sat in that room. They've contributed questions. They've seen the process. So we give you really good questions. We're a 10-year-old company. Our technology is really good as well. And, I think that's good. Another question, our apps are updated. These have everything that you will see on the National Registry. They have even concentrating on things that are new, spinal motion restriction, opioids, and naloxone administration. And the updates that the American Heart Association has released periodically since the 2015 guidelines came out are all in there. These are updated all the time. Matter of fact, when you log in, it checks the server, so we can update these on the fly. You don't need a new version to be able to make this happen. Let me get into some questions here, and I'm going to stop and look at these again. Drina asked, how long is the subscription last for the apps? There's no expiration date. These apps last forever, and they stay up to date. And I think that's good. Another question: would I recommend the workbooks that came with the textbooks? And I think workbooks are really designed to make sure you have the knowledge that goes with class. The workbook really kind of supports the textbook. And I think while it would be good to see you have the knowledge, I'm not sure the workbook is really designed to help you pass the National Registry. So let's pop a question up here. And I know that's what you're here for, and that's what I want to do. So let's look at this first question. Now, this first question, I have 5 questions, and I picked a different theme for each question. The first is pathophysiology. Now, I don't know how well your instructor taught you pathophysiology, but it's really important. Pathophysiology is the difference between memorizing and understanding. I am pretty fanatical about pathophysiology. My students, some of which are here, know that I really push it. And the pathophysiology that's really important really is about ventilation and respiration and perfusion. And those things just affect everything that we do. Not only our ventilation and breathing in the airway chapter, but anaphylaxis and shock, trauma and shock, heart failure. Everything has to do with pathophysiology. So we're going to put some questions up here. And I'm going to put the first one up here. And what I'm going to do is I'm going to put the question up. And I'm just going to be quiet for a little bit so you can read it. Not too long. I don't want you to sit around and wonder what's happening, but I want you to read it. I don't want my voice to give you any tips into what's important in the question. And what did we talk about? Read the question. Very important to read the question. The National Registry gives you a minute per question. Regardless of what exam you're in, you get a minute per question. The average length of time a person takes to answer a National Registry question is 31 seconds. So some questions are going to come up, you're going to look at it and say, okay, I think I got the answer. You're going to click it, you're going to submit it, you're going to go on, right? So you've built up some time. Don't create artificial pressure on yourself to rush through the test and make mistakes and miss things. Read the question. Sometimes I recommend reading it twice when there's a lot of stuff, and then look at the choices. And you may look at the choices and have to go back to the question. And we'll see how that goes. Here's your first one. All right, so unresponsive 21-year-old male was shot in the left upper abdominal quadrant. His skin is pale and diaphoretic. You auscultate clear lung sounds, and his neck veins are flat. His vital signs: pulse of 116, respiratory rate of 120, blood pressure 100/72, saturation is 92% room air. What type of shock should you suspect? So this is a pathophysiology question, and I don't think it's a particularly difficult pathophysiology question. But I like to talk about the four functional descriptions of shock. And you see those there: obstructive, cardiogenic, hemorrhagic, and distributive. All right. This gives me a chance to teach a little bit on these. Obstructive shock you might see in a tension pneumothorax or pulmonary embolus. Cardiogenic shock is generally an MI and heart failure. Hemorrhagic is from bleeding, sometimes called hypovolemic, because there's other ways you can lose fluid besides hemorrhage. And then finally, there's distributive. And distributive is when we have essentially the same amount of fluid, but the body doesn't distribute it well. And we see that problem occurring in anaphylaxis and sepsis. But there's reasons that we see things in this question that we can use to rule them out. Because what's interesting is that the chest and the abdomen are separated by the diaphragm. But remember, the diaphragm moves a lot, and that's what helps us breathe. It makes our chest cavity larger and causes air to rush in. And the diaphragm, when you exhale, comes way up under the ribs. So, in a shot like this, the diaphragm is, you don't really know if you have a chest or an abdominal injury. And we certainly have vascular things in that upper left abdominal quadrant, like the spleen. So pale and diaphoretic skin, to me, says that it's probably not distributive shock. Right now, with a pale and diaphoretic skin is because the blood vessels have contracted. We've increased vascular tone in our extremities. As a result of that increased vascular tone, our skin gets pale and it gets moist. The temperature changes. Blood coming to our skin helps keep it warm. So that cool, moist skin is because our blood vessels have constricted. And in distributive, that doesn't necessarily happen. We have a problem with our blood vessels opening up. So now we have three types here. Now, the neck veins are flat and there's clear lung sounds. So it says to me that's not like a tamponade or any type of problem with the chest or anything like that. The reasons our neck veins can be distended, also called JVD, jugular venous distension, is because blood from the head has trouble getting back into the chest cavity because of pressure. That obstruction, right? But these neck veins are flat. So we're going to rule out obstructive shock in this. And that brings us down to cardiogenic and hemorrhagic. And quite frankly, you have a person who was shot in the upper left abdominal quadrant, probably not his heart, and that leaves us with hemorrhagic. Now, I don't look at this question as particularly difficult. We started at a relatively easy level here, and we will get more challenging questions as we go on. If the National Registry puts something in a question, it's generally there for a reason. There's not a lot of fluff in these questions. Right? They're not going to be like your classroom tests. They're not going to be like some of the other ones you see online. There was a dark and stormy night. You and your partner were having dinner. You had the beef stroganoff. Your partner had chicken parm. When the tones went off, right? No, it's nothing like that. 3 sentences, a set of vital signs, boom, and that's what you got. They only give you just enough to make the decision that you need to do. All right. So sometimes one of the things people say after coming out of the registry is, it seemed like some of those answers, all of them were right, or it seems like all of them were wrong. I wouldn't do any of those things. And you know what people do? In their mind, they fight the question. And that's very counterproductive. It psychs you out, it wastes time, and it's not like the computer's going to listen to you and give you a 5th choice or change one of the choices. You've got to put them there. Now, there's 2 types you'll get when you sit for the National Registry. You'll get questions that are counting towards your score that the computer adaptive test gives you at a certain level, and then will gradually increase until you convince the system that you have reached entry-level competency. But there are also pilot questions in there, questions that will not count towards your grade. Those are being tested to be put on future exams to make sure they are valid. And this, if you do the minimum of 70 questions, up to 10 of those questions can be these pilot questions. So if you get a weird question, don't freak out, right? But if you do get 4 and you don't like the choices, and it's a good question, it's been validated as a good question, one of those answers is going to be better than the rest. It's going to be the right answer. Other ones are going to be choosable. There'll be something about them that you like or don't like, but there's going to be one that stands out for a reason. And the way we figure out which one that is we match it with the information in the question. Let's take a look at the next question, question number 2. I'll give you a minute to read it. So, a 46-year-old male was shot in the head with a .22 caliber pistol. On arrival, he does not respond to painful stimuli. His vital signs are blood pressure 110 on 74, pulse is 106, respiratory rate is 12. You should. And boy, isn't that the classic National Registry, you should. Sometimes you'll see you should next or you should first. And that's very important. You need to know, what to do. This is more of a general, you should, and one of these is going to be correct. So we have 4 choices. Assist his ventilations at a rate of 20 breaths per minute. Apply 100% oxygen and immobilize him to a backboard. Cover the wound and rapidly transport. Or maintain his airway and prevent seizure activity. Now, every one of those choices probably has something that you like. And that's what this does. This is why we have to go through and take a look and figure out what these things are. Now, there are some things that I want you to be able to rule out, okay? Choice D, maintain his airway. That's a great one. But the second part, prevent seizure activity. I'm not sure how you could prevent seizure activity. If you're a paramedic, you could probably stop it with a benzo, right? But you can't prevent seizure activity. It looks like it's a really cool answer, but scratch it. You can't prevent seizure activity, period, right? And choice B, apply 100% oxygen and immobilize him to a backboard. All right. Problem with that question is penetrating trauma, we don't immobilize. All right. It's been at PHTLS for a couple of editions in the class there. The American College of Surgeons, other people have come out and said, you putting a person on the backboard and strapping them down and everything else, it just takes time away that you should be getting him to a surgeon, right? Put him on a backboard, put him on a stretcher, and go to the hospital, right? So we've gotten rid of B and we've gotten rid of D. So now we have two. We have assist his ventilations at the rate of 20 breaths per minute, or we can cover the wound and rapidly transport. Now, if we were ventilating this person, all right, we wouldn't ventilate him at 20 breaths per minute. Our ventilation rate would be 10 to 12 breaths a minute if he was in failure. But right now, his respiratory rate is 12, his pulse is 106, blood pressure is 110 on 74. I see no indication in that stem where you need to ventilate the patient, nor do I see any indication of him having increased intracranial pressure where you might want to ventilate to try and get his end-tidal CO2 into a normal range if it wasn't. So that doesn't make any sense either. What do? For the wound and rapidly transport. So this question starts with a pretty strong statement. Shot in the head with a 22 caliber pistol. You know what you do? You assume that's really, really bad because he was shot in the head. And sometimes that leads you to pick a choice that makes you say, okay, what are we going to do? Now, there are people that have probably given you advice about taking the National Registry. People who mean really well, maybe people that you ride with, or you've done clinical time with, or friends you have that are in the EMS or the fire service, right? And they'll say things like, "Well, if you're not sure, always pick oxygen, or you should always do the airway first. You should always do this." Anytime someone gives you advice about the National Registry and uses the word "always," disregard it. Because the National Registry is written in a way that there's no such thing as always, because what happens is it really depends not only on the correct answer, but what the other choices are. So if someone says, oh, always do oxygen first, which is not right, or always do airway first, what if airway isn't a choice? It's just not the thing to do. Every question you have to look at without rules and preconceived notions. Oh, he's shot in the head. I have to do something big. You know what the big thing you can do for a trauma patient? Cover the wound and get him to a place where he can get a neurosurgeon, right? That's what you need more than anything else in this. So I thought this is a little bit more of a challenging question, largely because I think that you want to do things here, but the truth is doing less in this case is actually more. None of the other choices are right clinically or possibly, and that's why they are here. All right, so let's look. Question number 3. Read carefully. Sometimes you have to, the question part of the question in the educator lingo is called the stem. You have to read the stem really carefully. Other times, you've really got to read the choices carefully, largely because they all have this certain amount of choosability. And just for the record, the National Registry is not trying to trick you, nor will they ever try to trick you. The only thing the National Registry will do is to give you a challenging question that's going to have you make a decision based on the information that's given. That question has been validated by a bunch of students taking it and put in at a certain difficulty level to test your knowledge. They will never trick you. Don't read into questions and see if there's hidden meaning or anything else. What's there is there, and what's not there is not there. So here's the question. I'll give you a minute to take a look at this. All right. So a 52-year-old male has bright red blood in his urine. Oh, I hate when that happens. He complains of left flank tenderness and thirst. His skin is pale, cool, and diaphoretic. He tells you an hour ago he was the restrained driver of a car involved in a crash. He tells you the driver's door was pushed in a foot, but he refused treatment. You should. Before we get into the choices, let's look at the question again. He has bright red blood in his urine. You know, bright red blood is fresh blood, right? No matter what you get, no matter where it comes from. You know, if it's digested or been hanging around a while, it might be dark or scant, but bright red blood means that just recently came out of somewhere. And that means something, right? Left flank tenderness. Well, the left flank, all right, now he was driver and the door got pushed in quite a bit. So he's got the potential for that left flank tenderness and blood in his urine to be a kidney injury. Not to mention there's seat belts and there's deceleration problems that can happen that can cause shears and tears of blood vessels and trauma to that kidney. And boy, kidneys are so vascular, right? What do kidneys do? They filter. They're so important, and there's so much blood passing through the kidney all the time that a problem there would be pretty serious. But if you wondered if that itself, was going to be serious, because mechanism of injury itself doesn't guarantee injury. However, pale, cool, diaphoretic skin, yeah, that says shock to me. They don't have any vital signs here. You have no pulse or blood pressure or respirations or oxygen saturation, but you got a guy that got creamed in a car crash. He's got bright red blood in his urine. He's thirsty, another thing that indicates shock. His skin looks like doo-doo. So, all right, that's what I want you to feel from this question, right? That this is a potentially serious thing, okay? So let's go through and rule some out. Collect a sample of urine. I don't think anywhere in your class you were taught about that. I know in the old days we were taught that if you have an overdose patient that vomits, save the vomit and bring it to a hospital. It was always funny watching somebody try and hand a bag of vomit to a nurse. It was not really funny to the nurse, and they didn't really want the bag of vomit. And we're not going to collect a sample of urine either. Now, since a person might be heading for surgery, we really don't want to have them take any water or anything by mouth. And if they are critically injured, the whole absorption of that isn't going to be particularly effective anyways. So, and with the potential nausea that can come from shock, last thing I want is somebody that's starting to go downhill vomiting. So no sips of water. So now we have two choices. Apply a cervical collar and immobilize him to a long backboard and administer oxygen and keep him warm. Okay? So there's no indication that he complains of any pain to his neck or spine here. And he's been walking around, or he's been out and about of the car for an hour. That certainly isn't leaning towards immobilization, but the thing is now, immobilizing to a long backboard really isn't done anymore. I mean, if you wanted to put a collar on, I'm sure you could have him lay on the stretcher and secure him to the stretcher. That's spinal motion restriction. People really aren't immobilized to long backboards now, so we really should. But what about A is going to give you trouble? I and others have probably said, well, we don't give oxygen on, just routinely give oxygen anymore, right? There's two indications of when I believe that clinically it's appropriate to give oxygen and when the National Registry is going to expect you to give oxygen. One would be in oxygen saturations that are less than 94%. All right, that's pretty easy. And generally we titrate up. We don't go with the big guns. If somebody's got a saturation of 92, we don't put a non-rebreather on and try and blow their hair back with oxygen. We put on nasal cannula at a couple of liters. We get up to 94, 96, right? 98 tops, and we're good. Man, we're really good. The other time we give oxygen is in really sick patients. Patients who have complaints of significant respiratory distress, or patients like this who are in shock. He's bleeding, he's thirsty, he has pale, cool, diaphoretic skin. It's okay to give oxygen. Don't rule out A simply because of oxygen. It's the best answer. And this is the way these questions are crafted. If you're an educator sitting here in this class, I know I have some educators here. You're thinking, boy, these are hard questions to write to be able to have an answer that's correct, but not easy. So in this case, because of his pale, cool skin, because it's trauma, he's bleeding, the oxygen's okay, and keep him warm, right? Normothermia, keeping trauma patients warm is probably one of the best things that we can do. We talk about a trauma triad of death, of hypothermia, acidosis, and coagulopathies, and everything really kind of hinges on that temperature. A good friend of mine, and we recorded audios together for Limmer Education. And if you're in the back of the ambulance and you're not sweating, your patient probably isn't warm enough. Right now it's a beautiful day in East Texas. It's 78 degrees out there with a breeze, but you know what? That's still 20 degrees lower than my body temperature. So keeping people warm is so important in shock. So in this, that's something important to know, and that it's okay of oxygen in this situation. And A is the best choice of all of these. And there's a reason why we didn't pick the other three. Now, remember, some of these you're going to look at and you're going to go through and say, okay, like that first question we did. Yep, hemorrhagic shock, hypovolemic shock. Yep, that's it. It's pretty clear. Other times you're going to have to go through and say, these are harder. There's two ways to get a question correct. One is to know the correct answer. The other is to figure three of them aren't the answer, meaning the one that's left is the correct answer. And you know what? They're both end up with the correct answer. But that's what this was about. This was about reading and thinking in this. And that actually is what the fourth question is about here. And the theme for this question is think, don't jump. Right? You're going to go in there, and now not only do you have the whole national registry thing to think about, you've got sanitation and all these other rules and worries about things. And what you really need to do is you need to get in there and clear your head and do one question at a time and think about each one. Feeling pressure to move ahead only hurts you. Right? What would be ideal? You go in, you get 70 questions, bada bing, bada boom, you're done, right? And if you take a minute on each question or longer, it doesn't matter. Answer the questions well, and you'll get less questions, right? Let's look at the question. Let you read this for a second. All right. Before I read this, I just want to thank you for some of the things that you're writing in the questions. I speak. There's a few things I want to address. Let's do this question first, then we'll get in to a question that Kimberly sent in, and then I like Anne just asked something here. I have to address as well. So, a 45-year-old female has left-sided weakness that started 20 minutes ago. She has difficulty finding the right words to answer your questions. Her vital signs are pulse of 86, respiratory rate of 14, blood pressure of 142 on 74, and she's saturating at 96% on room air. You should next. All right. So she's 45, and she has left-sided weakness with a relatively sudden onset. That's another thing. And there's things that just aren't taught in class or aren't given the importance that it should. We go through the sample history and OPQRST, and sudden versus gradual is so important. Look at respiratory conditions, right? Sudden things that happen are like a spontaneous pneumothorax and asthma attack. And gradual things are pneumonia and maybe COPD exacerbations, or people start to get worse over a period of time. They'll call you at a crisis point, but it's been getting worse over time. So starting 20 minutes ago is important, right? She has difficulty finding the right words to answer your question. So you can look at this and you can, that first question, and you can pretty easily say, boy, it looks like a stroke. So we got the vital signs, and we're going to talk about vital signs. That was Kimberly's question. You should next. So notify the receiving hospital, call a stroke alert, oxygen by nasal cannula, oxygen by simple face mask, right? A little less than a non-rebreather and amount of oxygen given, or assess her blood glucose level. Well, she has an oxygen saturation of 96% on room air, and she has no other signs of hypoxia or respiratory distress. So let's rule out B and C. Okay? Remember, this question is about thinking. People might want to jump and say, okay, notify the receiving hospital of a stroke alert. But the answer is assess her blood glucose level. Now, there are a lot of things that can look like strokes, okay? And one of those is hypoglycemia. Hypoglycemia comes on suddenly, like about 20 minutes before, right? We don't know if she has a diabetic history or not, maybe. But before you can call that stroke alert, you've really got to know that she isn't hypoglycemic. Other things that can mimic strokes are seizures. I have had both hypoglycemia and stroke patients. You get there and their face is droopy and they're hanging out on one side of their body, and I'm like, wow, look at this stroke. And then in the seizure, post-ictal, they start to come back and it goes away. And in the blood glucose reading, if we find it low, we give them glucose. You know what's probably going to happen? She's going to think of the right words to say, and the left-sided weakness might go away. Now, don't go with arbitrary rules. You can't give a stroke patient glucose, right? That's not true. The correct way to look at that is stroke patients will do better if they are normoglycemic, meaning not low or not high. I'm not telling you to give glucose. I'm telling you to check her blood glucose level before you call the stroke alert. And if you don't do that, I want you to think of two consequences that would happen. One is you're going to get into the hospital and they're going to have the stroke team there and they're going to be standing by, and then they're going to find out it's a diabetic patient, and that leads to problem number two. You had a treatable condition that you didn't treat, and you could have made her better right away, and you didn't, and that's bad. That's why we check the blood glucose level, right? Avoid rules, these arbitrary rules. Well, why did I check the blood glucose level? I can't give her glucose anyway. It's a stroke. No, we want to think, right? This is about thinking. EMS is all about thinking. And we say, what could be causing this? Well, it's probably a stroke. She's relatively young. A 45-year-old can have a stroke, but it should make you say, I should want to check her blood glucose just to make sure before I call out the big guns at the hospital. That's what this is about. All right. So Anne said something. In my class, when we do patient scenarios, we're supposed to always give oxygen via non-rebreather at high flow of 15 liters per minute. When on the NREMT should I consider oxygen? I think we've kind of gone through that for you, Anne, but I just want you to know that a lot of people are told that, and it's wrong. Oxygen is not the wonder drug. Oxygen can cause harm. If someone has an oxygen saturation like in this question of 96% with no signs of distress, they would get no oxygen. And that's really hard for some instructors out there to say. We've been given oxygen. We were told years ago, oxygen's the wonder drug, right? So give lots of it. It can't hurt. Well, when you have an anaphylaxis, you don't say, I've got 3 EpiPens in the ambulance. Heck, I think I'll give them all right now. You would never do that, right? Why? Because epinephrine's a drug and it can cause harm. We need to think about oxygen that way, right? So if you've had this in your head, this is another thing that people that have been out of class for, I'll say, oh boy, give them oxygen. That's usually a good answer. If that's the only one you don't know, pick that. Well, the only time we give oxygen now is if patients are hypoxic, and I think that's I think that's a good thing um, to do. And I think there's also some questions came in about immobilizing a patient. Um, we have a handout on spinal motion restriction. I'm going to see if my people can get that put into the handouts while we're talking here. We can actually give guidelines for spinal motion restriction. Basically, what happens is we really don't put people on backboards except now as a transport device. And the truth is, people who have a back or a neck that injured don't generally want to move it anyways. So if you get somebody that's in a car, put a seat collar on them, spin them out onto the backboard, and then slide them off the backboard onto your stretcher. Or if they're outside the car, put the collar on and say, please gently sit down in the on the stretcher. And then we're going to lay you back and we'll secure you. That motion restriction. That's what's done now. Spinal immobilization. Um, it really isn't done. Now, I'm not saying that you'd never use a backboard. There are probably two times that I would probably use a backboard and keep the patient um, on the backboard. One would be is if I had an unresponsive train wreck of a trauma patient, where I'm kind of using that backboard to splint an arm and a leg, and just when that kind of becomes a big splint, I might use that. Keep them on the backboard. And the other time is if I think I've got a trauma patient that I'm going to have to do compressions on. I think having them on a backboard really wouldn't be a bad idea. But remember that we don't use always and never. We have to use creativity. Backboards were a problem. It hurt patients. They literally were sore by the time they got to the hospital. It was just a really bad thing. Um, Obese patients, their bellies would shift and would compress their chests and they couldn't breathe. Pregnant patients would get hypotensive in that third trimester of pregnancy. So, those are the reasons that we do spinal motion restriction. And like I said, I'm going to see, I think we'll be able to get that handout for you in the handout section here on GoToWebinar. Now I'm going to talk about how to evaluate a National Registry question here. And this is going to come down to one thing that Kimberly sent in. And I think she had some good questions. Now, I have a friend that teaches at the Army down at Joint Base San Antonio, the old Fort Sam Houston in San Antonio. And we were talking on the phone one day, and he says, I've been teaching people, and they've been coming out of the registry, and the more I talk to people, the more I think vital signs really aren't that important in National Registry questions, just with a couple of exceptions. And I'm like, really? You don't think that's important? And so we start talking about what's important. So let's give you three things to look at. And by the way, these things go for patients as well. And when it comes to the National Registry, all the questions I've shown you here today aren't trickery. They're National Registry style questions, right? Written by somebody very familiar with the National Registry. And they ask you to make a judgment just like you would on the street. I don't want you to think that, they're going to tell you, your instructors are going to tell you, well, sometimes, I just got to teach you so you can pass the National Registry. You're going to have to figure out the street on your own. And that is so not true. Because the way we're going to evaluate questions looking at this sheet is exactly like you're going to look at patients on the street, So first, the mental status, right? It's not always clear cut. But if the patient complains of something, or if it says that, there's something in there, a normal mental status is significant. Because a patient with a normal mental status generally is not in respiratory failure, right? Respiratory failure involves two things, right? It involves decreased rate or decreased depth of breathing. But by the time you get to failure, you're not going to sit down and recite the Gettysburg Address. You're going to start to have an altered mental status. So that mental status is a really good thing, not only on the National Registry question, but on the street. There's no such thing as a little altered mental status. If somebody is anxious, that's one of the signs of shock. People are acting somewhat goofy, or maybe they're really outrageous or yelling. Hypoxia, hypoglycemia, respiratory, all these things cause altered mental status, serious things. Even a little altered mental status. Gee, he's just not right. When the family says that, that means something. So number two is look for signs of criticality. Now, in a patient, you look for these things in person, but in a test question, you look for these things in writing. but they're valid regardless of where you see them. Now, things that describe respiratory failure: patients who are sleepy, patients who are tired, patients who are gasping, right? Gasping breaths. That might be agonal breathing, and that's like near death, anyways, right? Shallow, right? Those things indicate criticality and also the need to ventilate. There's going to be times that a patient will be somewhat responsive but be in respiratory failure, and you should choose to ventilate them and not just put an oxygen mask on, right? So, respiratory failure is when we're going to have to ventilate a patient. And why are they sleepy? Why are they tired? Well, because they've used up energy trying to breathe. Chronic obstructive lung patients, um, emphysema patients are often really, really skinny. Why? They're using up all their energy to breathe. One source I read said up to 80% of the energy used in a patient with emphysema has to do with breathing. And if their breathing gets more difficult, there's very little reserve left. That's why they're being tired and head bobbing and gasping, and they get shallow breaths. Those words, those things that we see in patients are vitally important. Number three, the complaint. Right? Often in the first sentence in the National Registry question, one of the first things we talk to a patient about, right? Is it chest pain? Is it something that indicates signs of a stroke? Is it serious trauma? Sometimes these complaints require us to transport promptly and do more work in the ambulance on the way because it's important to get them to the hospital. And ACS, by the way, is acute coronary syndrome. And that is term that the Heart Association has started using, and that involves acute myocardial infarction, MI, and also unstable angina. But the other thing that happens is that sometimes there are treatments, certain complaints, there's things, and aspirin's a great example, right? If somebody's got chest pain or chest discomfort, it might just be a heaviness. It might not be pain. A lot of times it is just some kind of heaviness or indigestion, or my left shoulder hurts, right? But you think that it's cardiac related, aspirin can be given early. Aspirin should be given early. People mistakenly tell me all the time, I can't give any medication. They say it very convincingly, just like that, until I've got vital signs. Yeah, that's not true. Do you know emergency medical dispatchers now tell people, do you have any aspirin in the house that you can chew? Why don't you do that? They don't have vital signs. If they don't have an allergy to aspirin and no active GI bleeds, bam, and they've got chest discomfort, you think there's a cardiac complaint nature, go with the aspirin. Before oxygen, before nitro, right? Those things are important. That order is important. Remember, you should first, you should next, right? So when you see oxygen, nitroglycerin, aspirin, or transport in a patient with chest discomfort, aspirin is going to be that priority. Then finally, the vital signs. Now, it's not that they're not important, but I put them last here because there's a lot of stuff you're going to find before those vital signs. And that's where it's sometimes different than the street. Boy, there's nothing cooler than pulling out a sphygmomanometer, the blood pressure cuff, or hooking somebody up to the monitor and hitting the button and getting the blood pressure. We're doing things. It feels good. But the truth is, some of these observations that we make, seeing the pale, cool, clammy skin, those signs of criticality, those things tell us more than the vital signs. There's sometimes on calls that when you get to the vital signs and you find a low blood pressure and rapid pulse, you really shouldn't be surprised the patient's in shock if you've paid attention. So Kimberly, I think that answers a little bit of your questions, but there's a couple of really good things here. She says, I understand that the suctioning for 15 seconds rule, which is in our books, is not how it would work in a real patient. In the real world, we suction until the stuff is no longer able to be aspirated. That is true. And just for the record, my EMT book for several editions has not had that 15-second rule in there. Suctioning for 15 seconds and then ventilating, a giant hunk of potato into the lungs, I mean, that's fatal, right? And it's more fatal than a little bit more hypoxia while we suction. So Kimberly's question is, should we adhere to that 15-second rule in the books or use the real way in the National Registry? Use the real way on the National Registry. They're not going to ask you how many seconds to suction, right? That came from the hospital. That whole 15-second thing, right? Or how about this one? How about Well, you should pre-oxygenate a person before you suction. Well, if I could predict when they're going to vomit, I probably would play the lottery before I would. I mean, we don't know when they're going to vomit. We can't pre-oxygenate. We taught a lot of really dumb things. We had really dumb things in our book for a long time because that's just what everyone said, right? But it turns out that what do we want to do? We want to ventilate people good all the time, not too much, not too little. If they vomit, we want to quickly and efficiently get that stuff out of there, um, and then start ventilating again. Period. That's the right way. That's the National Registry way, and I don't think there's going to be a concern. Now, the other thing is Kimberly asked, what source should I use to memorize vital signs for the National Registry? I find that some different sources have different pulse rates and respiratory rates for different ages. Um, I don't really, I mean, I've been teaching for a long time and I don't really care if my students memorize vital signs, right? I want them to look at the pulse pressure, the difference systolic and the diastolic, right? The pulse pressure should be at least 25% of the systolic pressure, right? So generally it's, 25 or 30 at a minimum. So that's a really good indicator that the patient is in compensated shock. Nobody really should be above 160. Nobody should really be below 60 with signs and symptoms, problems. I'd be happy if you knew that, right? There are some things we do that if we have a newborn, um, and a young pediatric patient, if their pulse rate is below 100, we ventilate, and if their pulse rate's below 60, we compress them. Those are good numbers to know. Everything else is somewhat relative. What should you know about, especially with kids and vital signs? Remember the pediatric assessment triangle, their appearance. Are they screaming and crying and latching on to mom? In which case you say, okay, doesn't sound too serious, as if they're limp, just lying there, right? And are they breathing really hard, using accessory muscles? Their effort, their breathing effort, and then their circulation to their skin. It's their skin like? Are they pale and look like junk? That's really the stuff that's going to give you the information. You can memorize vital signs. The fact is, difference of 5 or 10 beats and pulse a minute. Nobody's going to ask you anything that exact, anyways, on the National Registry, Kimberly. I mean, so you're going to be okay. Now, I know that you probably wanted me to give you this is the source, memorize them. What I'd rather have you do is think clinically rather than memorize, and it will serve you better. All right, last question. I call this one "If It Walks Like a Duck." I actually said this to my students in class. The I said, if it walks like a duck, if it looks like a duck, if it quacks like a duck, it's a duck. And we'll always see if you can figure out how that applies to this question. All right. Hey, Monica, good job. I'm glad you're doing well here. Maybe that helps get some mojo back. I hope that you continue to practice and do well. 49-year-old male complains of left-sided chest pain. He tells you it started an hour ago, and it has been constantly 4 of 10. He denies past medical history. He has a 38-pack year smoking history. You auscultate fine crackles in his lower lungs. Blood pressure, pulse of 96, respiratory rate of 16, blood pressure 154 on 96, sitting at 96%. You should suspect. Oh, that's a good one. Now, remember I told you about choosability? Sometimes you got to figure out what's important in a question. Now, I think one of my students today in my class said, well, how do I know what's important and what to do? Like 49 years old. Can a 49-year-old have a heart attack? Yeah. Can he have lung cancer? Sure. Can he have emphysema? Sure. Some things are more likely than others in this case. Now it says he has a 38 pack year smoking history. So means a pack year smoking history is you take the packs per day you smoke times the number of years you've smoked, and that gives you pack years, right? Because if somebody smoked one pack a day for 50 years, it's the same damage to the lungs as 2 packs a day for 25 years. So that's why we have to quantify that as pack year smoking history. But that 35 pack year smoking history, you see that in the question, you say, could he have lung cancer or emphysema because of that? Okay. That's why this is choosable. But what are the chances that lung cancer and emphysema started an hour ago? That's where the issue is. That's where this is a duck question, all right? He's got chest pain, even left-sided chest pain, right? There's the chest pain for MIs. You just really got to keep an open mind. Sometimes there's no pain, right? It can be in the center. It can be crushing. It can even be pleuritic sometimes. One paper said 10 or 15% of heart attacks people, they describe pleuritic chest pain, which is pain that changes when they breathe. So that left-sided thing, don't let it throw you off. He's got chest pain. It just came on, so it's a sudden onset, and it's 4 on 10, right? So that's pretty significant. And there's crackles in his lower lungs. What does that mean? It means there's fluid in his lungs, right? He's got hypertension, which is a risk factor. He's a smoker, which is a risk factor for acute myocardial infarction. Chest pain, 4 on 10, came on suddenly. He's got crackles in his lungs, which means he may have a little bit of heart failure, some pulmonary edema. He's got hypertension and a smoking history, which are risk factors for heart attack, and a sudden onset. Acute myocardial infarction. This is the duck. It walks and looks and quacks and craps like a duck, right? Prinzmetal's angina, a specific kind of angina. If you haven't heard of it, don't pick it. Okay, I mean, really, it's a specific kind of angina, but that was in there. Okay, lung cancer, emphysema, that's there because of the smoking history. Prinzmetal's angina, that's there to give you a really big word to make you say, oh, gee, maybe that's why it's a heart attack. It's acute myocardial infarction. That's what it is. All right, I hope you did well on that one too, Monica. So just a couple of things I want to say is before we click on, we're hitting the hour part here. So if you haven't guessed, as an educator, I can certainly talk. I love to teach, and I hope this has been very valuable for you. These questions. If we didn't get to your question, we're going to try and get to it offline. We're going to send some things out and follow up emails. There's been a lot of questions here, a lot of good questions, and that's it. In our chat feature on the screen right now, there is a link for spinal motion restriction handout. I don't see it on my thing here, whose name asked for that. But if you're not sure about spinal immobilization versus spinal motion restriction, go into the chat, click on that link. You'll get a PDF handout that will explain how to assess and how to treat for spinal injuries based on an American College of Surgeons, EMS physicians position paper, which I'm confident that the registry also references for their exam. All right, so we're going to try and get you questions out for this. Limmer Education, doing this, putting these questions out here, teaching you, this is what we do, everything we do. Our PASS apps, which I told you about, our review apps, EMT, and paramedic. We also have a website, emtreview.com, paramedicreview.com. If you're looking for more detailed study, where you want to be helped in how to study, have a little bit of structure, have more of these live online sessions with me, EMT.com and paramedicreview.com have weekly live sessions, as well as a lot of different study resources, interactive exam review, diagnostic exams. It's more of an immersive exam preparation experience. I have a lot of people there that have times we've had really outstanding success with that, and I'd love to have people come in before they fail once or twice and actually be more successful. We have a lot of stuff. I would be honored if you would consider us for your study. We get lots of We find lots of people saying good things about us. People, feel like we make a difference for them. We've had people on multiple attempts who finally understand the questions and go in with that mojo to make it work. Dr. Antevi, who's just an amazing and brilliant physician that I have great respect for, recommends this, which of course makes me very happy as well. Now, we've been going on for a while here. I'm just going to put up ways to get in touch with us. I think it's very important that you are able to reach us. We have email. We're on Facebook. We put fun on Facebook. We're on Instagram. We're on Twitter. We're everywhere that you are, I guess. And I'm going to leave it at this. I found the time has flown here. I've enjoyed this. I hope that I've given you information that will help you pass the National Registry and get out there. I hope that EMS gives you the joys and the friendships and the experiences and the cool stories that it's given me over 40 years, and perhaps maybe you'll even get into education when you're done. I want you all to take care. Please be safe, study smart, stay healthy with all this crazy stuff going on, and go out there and do good things. Thank you for being here.